in basic of ultrasound, and there are many things which you will learn about the machine in the station. Just a brief overview. Why you need ultrasound? Obviously, it's a real-time image guidance, and it's an eye to us, because earlier we used to do a blind procedure. It was all landmark guided or PNS. But if the anatomy is altered, it will be very difficult for you and for the patient just poking around with a PNS, with a landmark technique. But if there is an altered anatomy, you can see in ultrasound, and you can just give it. It's very pain-free to the patient also. So it reduces the prick to locate nerves. It can detect an intravascular or intraneural injection, helpful in altered anatomy. The dose of local anesthetic is decreased because you are seeing and just depositing the drug near the nerve. And that's why the onset, the duration and the success rate is faster. Just really covering the basic physics, various ultrasound probes, the machine, how to visualize the needle, and what are the signs of sonography, signs of successful injection. What is the ultrasound? It's nothing but a mechanical longitudinal wave with an area of compression and relaxation, and which cannot be heard by a human ear. And the frequency is between 2 megahertz to 16 megahertz. This is the way ultrasound is produced, which you see on your on the monitor. The electrical wave comes from the machine, and once it reaches the transducer has got a piezoelectric crystal in it. This piezoelectric crystal converts the electrical impulse into a sound wave, and this sound wave again travels inside the tissue. Depending upon the concentration of the piezoelectric crystals on the transducer, the frequency of wave changes. More the concentration of the piezoelectric crystal, more the frequency of wave which is generated, and less the crystals, it's vice versa. Now this sound wave again travels inside the body, and either it will be transmitted or reflected back to the probe, or it might be scattered depending upon the tissue which it hits, and depending upon the acoustic impedance, which I will tell later on. It decides the nature of the wave, and ultimately that wave gets absorbed as a heat or gets attenuated. Now the amount of wave which returns back to the transducer, the probe, again by the piezoelectric crystal, it is converted into a electrical energy, and depending upon the intensity of wave which is coming back, it is depicted as a dots on the screen, and that is what you see on your monitor. So this is a brief how a ultrasound wave is created and you see on the monitor. From the clinical perspective, there are two key concepts: the resolution of the image and the penetration. In our regional anesthesia, we are more concerned about the axial resolution and lateral resolution. The axial resolution is how clearly you can see two structures which are above and below on the ultrasound machine, and lateral, how clearly you can see two structures which are just side by side. And penetration, how far the ultrasound wave penetrates inside the body. These two decides the nature of image, and this is dependent upon the frequency of wave which is generated by the probe. More the frequency, the resolution will be better. Means the axial resolution and lateral resolution will be better, but the more the frequency, the penetration is less. So why I am telling this? This decides the nature of probe which you will select while doing your blocks. There are two types of probes which we regularly use: the linear probe and the curvilinear probe. The linear probe has got a higher frequency, so it is good for a superficial blocks. Almost maximum blocks which we do under regional anesthesia, we use the linear probe. Only few blocks, mainly the deep blocks, the lumbar plexus block, if you have got a obese patient who has got a infraclavicular, you have to give an infraclavicular to image deep structures. There are three things which we should know. Attenuation. What is attenuation? It is the decrease in the intensity of wave as it travels inside the body. Because as the waves goes inside, it either gets absorbed, it gets scattered, it gets reflected, and the intensity of wave decreases. And more the frequency, more the attenuation. And in our machine, we have got a control, that is a gain control or a time gain control to take care of that. If you have got more attenuation of the wave we are not able to see, you can change that gain button. I will show what are the gain buttons. And focal zone. You should always want, because once the wave comes out, it converges at a point, and after that it again diverges. The convergence point is called the focal zone. You want your structure, the structure which you want to block should be just at the focal zone, and this can be taken care by the depth setting button in your ultrasound machine. Acoustic impedance, as I told, the different tissues have got a different acoustic impedance. More the acoustic impedance, more the ultrasound wave will return back to the transducer, and bone has got the highest acoustic impedance, so almost all ultrasound waves goes back to the transducer, and you see that structure as very bright. I will tell what are the echogenicities. Now this is the most important thing. In ultrasound, everything is black and white. Okay? So there are four types of structures, echogenicity, which you see in the monitor. One is isoechogenic, that is the structure is same brightness or the echogenicity as the surrounding tissue. Hyperechoic, the structure is bright. Okay? Hypoechoic, the structure is dark, but it's not completely dark. And anechoic means the structure has got no echoes. It appears completely black. So how does a hyperechoic image appears? The waves come from the transducer, it hits the structure, and almost all waves return back. And once you will see that structure as a hyperechoic image on your ultrasound image, on your ultrasound monitor. And anechoic means none of the wave is going back to the transducer. Every wave is crossing the structure and transmitted, and it gets absorbed. So we will see a black structure means anechoic structures. Depending upon this, you have to identify the structure. The black and white are the identification. So how does the nerve and muscle look? Peripheral nerves are mainly hypoechoic fascicles, but they are surrounded by a hyperechoic connective tissue. So they have got a honeycomb appearance. Generally, the nerves appear hyperechoic, but it depends upon the surrounding structure. If the surrounding structure is a muscle, the nerve will appear as a hyperechoic structure. But if the surrounding tissue is a fat, the nerve might appear hypoechoic. And the nerves above the clavicle are always hypoechoic. Below the clavicle, they become hyperechoic as they become more distally. Why? Because above the clavicle, it is only the neural tissue. The ratio of neural tissue to non-neural tissue is 1:1. But as the nerve goes below the clavicle, they carry on more connective tissue in their course, and they become hyperechoic. Muscle is always hypoechoic. Okay? This is how you see this is the interbrachial plexus in the interscalene groove. You can see the nerves are hypoechoic, but the same nerve, the median nerve, is hyperechoic. So above clavicle, it's always hypoechoic. Below clavicle, it's hyperechoic. Tendons are hyperechoic. So how do you differentiate? Because see, this is a median nerve, and you have got these tendons. It's almost same, but one thing is called anisotropy, which I will tell later on. Only thing you can differentiate, you can contract the muscle in that course. The tendon will move, but the nerve will not move. Subcutaneous fats, they are round oval hypoechoic structure, but you will find a fine hyperechoic septa separating it. And the bone, they will appear hypoechoic, bright hyperechoic, followed by a posterior acoustic shadow. Fascias, they will appear always thin hyperechoic line, and the blood vessel. Blood vessels are anechoic because all the waves get transmitted back. So how will you differentiate? The artery doesn't get compressed on a moderate pressure, but the vein will compress. See, here the carotid artery and internal jugular vein, they appear both anechoic, but the internal jugular vein has been compressed. When the veins gets compressed by a moderate pressure. This is the way you can differentiate whether it's an artery or a nerve. Or you can put a color Doppler or a power Doppler modes to differentiate. In a color Doppler mode, in regional anesthesia, the color Doppler modes only helps you. It depends upon the flow of the flow of the blood towards the transducer or away from the transducer. Okay. Pleura, it will appear as a hyperechoic line, and you will have a lung sliding line with a common tail artifacts. This is the thing which I was talking, anisotropy. Anisotropy is an angular dependence. It is a term used. Median nerve is appearing slightly less hyperechoic. It is almost hypoechoic. The importance of anisotropy is you should always have a good manipulation of the probe to get an optimal image so that you can see a nerve very nicely. That is the importance of this anisotropy. Now coming to the nobology, this is required because obviously if you don't know how to drive the car, you can't go to your destination. So this is the basic monitor which you will be seeing in the workshops. This is the place where everything is controlled, and this is the monitor. You can enter the patient data, that anechoic structure, and you want to clear whether there is a vessel or not. Only thing you can get clear whether it's a vessel or not. It will not tell you whether it's an artery or a vein. You can know the vein or artery only by putting a pressure by the transducer. And this principle is the bar principle. Blue away, red towards. If the flow of the blood is towards the transducer, whether it's an artery or a vein, it will appear red. As the probe has been tilted slightly proximally, now the blood flow is away from the artery, and this radial artery is appearing blue. Now the probe has been tilted distally, now the blood flow is towards the probe. Now the artery is appearing red. So this is the Bart principle. So don't get confused that the blue which is looking is the vein. In regional anesthesia, it's different. Okay? Clear? Now pulse wave doctor. Now you want to know whether it's artery or vein. Just took a cursor, press this button, put in the middle of that anechoic structure. If it's artery, you will have an arterial waveform. If it's a vein, you will have a venous waveform. And by this, you can differentiate whether it's an artery or a vein. Now gain function. This button is the most important thing. This is the auto gain button. Once you press it, the machine automatically adjusts the gain. Gain is nothing but the brightness of your TV. Okay? And these buttons are for time gain compensation. If you put, now see these structures. If you have just scanned and you are seeing this structure, either you can put an auto gain button to compensate for it. If still you are not getting, you can go for a time gain compensation. Now time gain compensation, here either you can put a near gain. You want to make the near field bright, you can just increase or decrease the brightness of by setting the near gain button. If you want a distal field to be bright, you can just press this button to increase the brightness. The whole purpose is you want a good optimization of the image. Now this depth, It is important to select the appropriate depth. Now you see these 5 pictures. Here, the median nerve, obviously if you see nicely, you can give a good block. And this is by proper probe selection, optimal depth, optimal gain, and by doing some probe manipulation. Ergonomics is most important. If I do my block like this, I think after 1 year, I have already undergone 1 level cervical disc replacement. Next level will be very soon. So obviously you have to be comfortable. It should be man, patient, machine, right? Holding the probe is important. You should always hold the probe with your non-dominant hand by these 2 fingers and this resting on the patient. Because this gives you stability, you don't hurt your hand if the block time duration has taken too long. And secondly, during needling, the probe doesn't slip. So proper holding of the probe is important. Scanning plane. In ultrasound regional anesthesia, maximum scans are done in a transverse or a axial scan, because the advantage is it is easy to visualize the adjacent nerve, the structures and the spread of local anesthetic. So maximum blocks are done in a transverse scan. So maximum blocks are done in a short axis, right? Orientation marker. You should know which is medial, which is lateral, which is cephalad, which is caudal. And this is by the orientation marker which is present in the probe. You will have a ridge or a notch in the probe, and this ridge and notch usually corresponds to the upper left side of the monitor. Okay? And usually we have, when you are doing a transverse scan, we want to put that orientation marker to the right side of patient, and if you are doing a longitudinal scan, you want your orientation marker cephalad. Okay? So which is right, which is left, which is medial, which is cephalad, caudal, it should be in your mind, and this orientation marker helps in that. Probe manipulation, because you want an optimal image. Obviously if you are putting a probe, you can't see things very nicely, you have to do some manipulation. And the different manipulation, what we call the part pressure. Optimal pressure is required to prevent that gap between the probe and the skin. That air gap has to be removed. So optimal pressure, alignment. You can move your probe slightly up and down. You can slightly rotate the probe or tilt it to get an optimal image. Okay? Visualization of needle. Time. Am I exceeding the time? Wrap up? Okay, fine. Visualization of needle, I'm not talking right now, because obviously right now we will be just scanning, seeing. So I think the basic things is enough for you to do the hands-on workshop. Before just concluding, I want, as a Aura Executive Committee member, I want you all and inviting you all to the Aura 2019 on 4th, 5th, 6th and 7th July at Coimbatore. The early bird registration was closed on 31st December, but seeing the huge response, we have extended the early bird registration till 15th of January. We have crossed around 850 registrations, and you can win a prize. You can win a trip to Germany by participating in the quiz, and you can also win 25,000 rupees by participating in jam contest. So come be part of this organization, Aura Academy of Regional Anesthesia. Everything about regional anesthesia will be taught. People who are using only PNS. One hall will be allotted 2 days only for PNS. Nothing only but PNS will be talked. And in rest of the hall, it will be only ultrasound. So it is for everybody, even who are practicing landmarks, the hall, separate hall is there for that. So come, register, be a part of this organization or this conference. Please, inviting you all. Thank you.
রাজীব পাড়িদার একটা